Bismillahirrahmanirrahim. Assalamu alaikum. Welcome to Gastrointestinal Oncology Session 2. My name is Dr. Rizwan Sheikh. I am a consultant medical oncologist in hospital. I just would like to introduce Professor Asghar Naqi, who is chairing this session. He's a chair Department of Surgery, King Edward Medical University, and the president of Society of Surgery, Lahore section, and professor of surgery in Mayo Hospital, Lahore. So I welcome you, Professor Naqi. So in this session, we have 4 talks relating to rectal cancer and also some of the first talk is a total new adjuvant treatment in rectal cancer. The second is controversies in total new adjuvant therapy for rectal cancer. And third is organ preservation in rectal cancer. And the last is gastrointestinal side effects of immune checkpoint inhibitors. So let me introduce my first speaker, Dr. Khurram Khan. He's a consultant oncologist, University College Hospital, London, UK, and he's going to talk about total neoadjuvant treatment in rectal cancer. So Dr. Khurram Khan.
To the organizers, Dr. Tabinder, for the kind invite. And it's an absolute pleasure to be here with you in Lahore. So I'll be talking in next 20 minutes about the role of neoadjuvant treatment in rectal cancer. There are 3 main areas which I'll focus on. So first of all, TNT, which is total neoadjuvant therapy. What are the challenges? What is the evidence? And where the consensus lies? Then secondly, the role of immunotherapy. So I've divided it into 2 groups actually, although it's still rectal cancer, but we know very well that it's an entirely different biology and should be as such treated differently. And then the role of ctDNA, which is very close to my heart. My research was on circulating tumor DNA as well, and its role in personalized medicine. And then finally, we'll briefly touch upon the future directions. So I guess the first question is whether TNT should enter clinical practice. It actually already has. But what we'll do is we'll examine the existing evidence in first instance. So for locally advanced rectal cancer, is surgery the only curative option? Well, gone are those days when it was believed that surgery is the only curative option for these cancers. And over the last 3 decades, we've seen that the outcomes from rectal cancers have improved quite significantly. And this is attributable to obviously some improvement in surgical techniques with TME, multidisciplinary treatment, which is now much more common and well established in any good setups. Widespread screening, so early diagnosis of rectal cancer. And then I think the important part, which is what I'm going to focus on, is the neoadjuvant treatment. What we have to look at, though, is how can we better stratify our treatments to get better outcomes and reduce the comorbidities and issues related with surgical techniques or with different chemotherapy or chemoradiotherapy. So if you look at the data on the right side, the 5-year survival for T4B and 2 tumors is still not great. It's 15.6%. So there is clearly a room for improvement. And if you look at the evolution of rectal adenocarcinoma management, one thing which is quite clearly noticeable is that if we go back to 1980s and 1990s, the focus of the treatment at that time was surgery. And if you look at the right side of this arrow, you'll see that now we are moving towards the paradigm has completely shifted towards more use of neoadjuvant treatment. So this is perhaps one of the reasons why we are seeing better outcomes for our patients. If you look at the UK current landscape, you'll find that chemoradiation, actually, which is here in blue, predominates the management of rectal cancer. So most patients with early or advanced, locally advanced rectal cancer would be offered some form of radiation therapy at some point. So going by the 2 important guidelines, which are ESMO rectal guidelines and NCCN guidelines, again, what is clear is that patients are divided into early stage, intermediate, locally advanced, and advanced stages. And in the locally advanced and advanced cancers, again, either the short course radiotherapy or chemoradiotherapy predominates the management of these cancers. And this is from the level 1 evidence of low local recurrence rates actually demonstrated by various studies. Likewise, the NCCN guidelines synchronized with the ESMO guidelines. And again, what we see is that patients are divided into low risk and high risk groups. The low risk group is the T3N of any type, but with clear CRM, or T2N12 disease. The high risk group is T3N with threatened CRM, and T4N any or locally unresectable or medically inoperable. Obviously, here the role of MDT is critically important, because as a medical oncologist, when we sit in the MDT, what we ask our surgeons is whether they'll be able to achieve for these borderline patients R0 resection or not. And the surgeon can come back to you and say that the chances of that are 50% or more. And that's where you rely on that information, the quality of the surgeon and the quality of the MDT, where you can challenge your surgeon as well and ask the question that in last 10 years, for example, you've done X number of surgeries, the records should be transparent and available. So these two trials actually in terms of total neoadjuvant treatment are really important trials, Rapido and Prodigy 23 trials. They have a similar design, but essentially any high risk locally advanced rectal patients were included in both studies. And the key was slightly different sequence of chemotherapy or radiotherapy. So what you see in the Rapido trial is that the standard of care arm consisted of the standard CRT followed by TME and then adjuvant chemotherapy. Whilst so this was a control arm, obviously. In the experimental arm, you had first SCRT, then you had a few days gap, then 18 weeks of chemotherapy, followed by TME. So here you've started with the short course radiotherapy and then offered chemotherapy, whilst in the Prodigy 23 study, they started with the triplet chemotherapy, FOLFIRINOX or FOLFOXIRI, followed by the CRT, then TME, and then further chemotherapy. But the main idea is that in both trials, actually, they focused on total neoadjuvant therapy followed by surgery. And then it's debatable whether you go for further chemotherapy or not. And that's the area of debate, actually, because when you extrapolate data from Scott trial and IDEA collaboration, it is also clear that the role of 3 months versus 6 months of chemotherapy in total is debatable. I think this is the most important trial, the data from which are awaited prospect phase 3 trial. But this is a trial which we tend to follow in our practice for high-risk patients. So in this trial, they offered 6 cycles of FOLFOX chemotherapy, then restaged the patient. If they had more than 20% response, they would go directly for surgery and then offer adjuvant chemotherapy afterwards. On the other hand, if they had less than 20% response, then after restaging chemoradiotherapy, I further downsize the tumor, then TME followed by FOLFOX times 4. So this is actually data from our own center of patients who had a patient who had TNT and surgery for rectal adenocarcinoma. This patient actually had MLH1 and PMS2 loss and MLH1 mutation. So essentially MMR deficient tumor. So first we covered the patients with so basically MMR proficient tumors or MSI normal tumors. As I said in the beginning of my talk, one of the important entities now, which is well established, is those patients who have MMR deficiency or MSI high tumors. So in our center, actually, we were running a Keynote 107 study, actually 177 study, in which patients were offered, patients with metastatic disease were offered pembrolizumab. So based on the similar idea, we were quite keen to use our expanded access program, and we offered some patients with MMR deficiency neoadjuvant chemotherapy, which at the time was not standard of care, neoadjuvant immunotherapy, apologies. So this patient actually received 3 months of nivolumab and ipilimumab on individual patient access program, and then 4 weekly nivolumab. And after 9 months of the treatment, he is in complete remission. So if we focus more on the existing evidence, the phase 3 evidence or phase 2 evidence in this arena, there are two important studies, and I've taken these slides from ASCO 2022. So this was a late breaking abstract of PD-L1 blockade as a curative intent therapy in mismatch repair deficient tumors, locally advanced tumors. So we know that approximately 5 to 10% of the rectal adenocarcinomas have mismatch repair deficiency, and they are relatively resistant to chemotherapy. So the theory was that the checkpoint blockade would be highly effective because it has proven to be efficacious in metastatic setting, and the response rate was expected to be approximately 10%. So this was the hypothesis that in mismatch repair deficient rectal cancer, PD-L1 blockade may either replace chemotherapy, replace chemo and radiation therapy, and replace chemo and radiation therapy and surgery. So it was quite enthusiastic actually, but they considered all three things in the hypothesis. And this is the trial design. Dostarlimab, actually one of the PD-L1 inhibitors, was offered to these patients for those who had clinical stage 2 and 3 MMR deficient rectal tumors. So they were offered this treatment for 9 cycles, which were 3 weekly cycles, followed by imaging and endoscopy. Those with residual disease were offered chemoradiotherapy, and those were with complete clinical response had non-operative management. Now, non-operative management is actually something which is in the trial setting in UK, run by Royal Marsden as well, for MMR proficient tumors as well. In patients based on MR imaging, if they have complete response, they can go on this 3-monthly surveillance program. The data from that study are, however, awaited. So these are the study objectives. And overall response rate of PD-L1 blockade with or without chemoradiation was a primary objective of this study. And these are the response criteria. I'll not read it out, but essentially one thing to highlight is that it was an excellent, well-run study with all important parameters included, including MRI scan, endoscopic examination, as well as PAT-CR. So these are the data. So if you look at the patients enrolled, there are high-risk patients as well as early-stage patients, but vast majority were high-risk with T3 and T4 tumor staging and node-positive disease. So these are the patients which have generally the adverse outcomes in this cancer setting. Now, here is the most surprising element. So what was seen was actually, so this is one of the examples of a patient who had high-risk tumor. You can see quite a bulky, nasty tumor here endoscopically. MRI, you can see a bulky tumor, and it was lighting up on the PET scan. The investigators were astonished that at 3 months, actually, there was almost complete response, very little FDG avidity, and this was maintained throughout on the follow-up of 20 months following this treatment. The complete response here. And then they looked at all the individual cases, and the same pattern was observed. So 100% CR rate. So this was quite exceptional. And when we look at the endoscopic response from the time of treatment initiation, it was again the same results. So essentially, endoscopically as well as on the MR imaging, exceptional response to the treatment was noted. And for that reason, despite small numbers, this paper made to New England Journal of Medicine. So this is a summary of all the 11 patients which were reported in ASCO this year. Now, the second important study was the niche study. So the niche trial actually was presented by one of my colleagues, Mariam Chalabi. And this was a study which made to Nature Medicine, again, a very high impact journal, just small numbers. And this was the first initial landmark trial looking at MMR deficient patients with colon cancer. So since this is not the subject of discussion today, this was mainly to give you a background of what the niche 1 study was. And in that study, again, they showed excellent results. This is the data from our patients at UCLH, a patient who had a BRAF mutation. We know that these have aggressive disease biology, but MLH1 loss on immunohistochemistry, had a few weeks of immunotherapy, and then again, complete pathological response. So this is the niche 2 study design. This was an investigator-led study. The first cycle was that of nivolumab and ipilimumab combination, a combination which is quite commonly used in melanoma patients. And then the second cycle onwards was nivolumab for 6 weeks, and the plan was to offer them surgery afterwards. The important thing which I think I would highlight here, which should be part and parcel of any of the studies that we run, is the tissue collection. So you can see that they had tissue collection at each important time point. These are the study objectives: safety, feasibility, and 3-year disease-free survival were the primary objectives, and the secondary objectives were all the other important variables. But again, the focus, I would like you to draw your attention to the translational research part, which is DNA, RNA sequencing, single cell sequencing, and multiplex imaging. So you can see that the baseline patient characteristics demonstrate high-risk disease in vast majority of the patients, which is 3/4 of the patients. The primary tumor location, we know that right-sided tumors generally have adverse outcomes compared to the left-sided tumors, and this patient population had a lot of representation from right side as well. And these are the results. So all patients underwent surgery with 100% R0 resection. Again, quite exceptional outcome. Median time from first dose to surgery was just 5.4 weeks. So one of the concerns which our surgeons may raise in our MDTs is that, whilst patients are on some form of systemic treatment, the surgery may be delayed. So here what we saw was actually the surgery was within 6 weeks, which is again excellent, and there were no new safety signals. The outcome was 98% of the patients underwent timely surgery, meeting the safety primary endpoint. And this is, I think, the most popular waterfall plot of our generation, which was presented in ESMO this year. So you can see that major pathological response was achieved in 95% of the patients, and 2/3 of the patients had pathological complete CR. So I think that resolves the problem in this patient population. Although I was chairing a session in UK in one of the colorectal cancer days, and there was a debate because this is still not phase 3 trial evidence as to whether we rely on this and offer our patients immunotherapy or not. And we can again discuss that actually in our discussion. But personally, I do believe that this is strong enough biological signal to change our clinical practice. So in the next few minutes, I'll be talking about how to take this further. So we've talked about TNT, the total neoadjuvant therapy, in both MMR proficient and MMR deficient rectal cancers. But what is next? So I think the important thing is to focus on a couple of points. One is whether we can afford to achieve this comfortably, that some patients who have exceptional response to the treatment, they can be kept on watch and wait strategy. Obviously, this is quite challenging because you tell your patients that, yes, you have exceptional response, but the tumor can come back. And to anyone's mind, it would sound like a crazy idea to just keep them on watch and wait policy rather than offering them a curative surgery. However, and again, yes, this is quite difficult because at the same time, we know that with rectal surgery, as demonstrated in the previous session, there are serious adverse complications which are possible, which may have an impact on patients' quality of life. So ctDNA is the last part of my talk, circulating tumor DNA. We've been doing it actually in London in our center. It was part of my research as well. We were collecting serial ctDNA samples. The concept is that you can detect circulating tumor DNA in the circulation if the tumor is active, or you can detect those mutations which can be picked up, such as KRAS mutations or BRAF mutations or other mutations in the circulation. And we've demonstrated, again, not in the scope of this talk, but we published in Cancer Cell and in Cancer Discovery, and we demonstrated that the circulating tumor DNA gives you as good results as actually the tissue biopsies. So there is a prospective study which is looking at 159 patients with locally advanced rectal adenocarcinoma who had CRT and curative resection. Serial plasma samples have been obtained in this study, and they're looking at adjuvant chemotherapy to advise whether the patients should be offered chemotherapy or not. And I think the important thing here is that there are studies in colon cancer as well, and in the end, we'll need to extrapolate a lot of data The concept is that those patients where there is still residual circulating tumor DNA, i.e. you are able to pick it up post-operatively or after initial TNT, they perhaps are in more need of having chemotherapy rather than those who have negative ctDNA. And this is what was demonstrated in post-op ctDNA analysis, which detected minimal residual disease and optimized the treatment options. So in summary, unfortunately, at this point, the consensus about the sequence of the treatment is oddly lacking. However, it is clear that more patients are offered in good MDTs neoadjuvant, total neoadjuvant therapy. Whether you go with the Prodigy approach or whether you go with the other approach of offering chemotherapy, radiotherapy first, short course radiotherapy followed by chemotherapy, I think it is immaterial. The main thing is that for high-risk patients with threatened CRM, it is clear that they should be offered some form of neoadjuvant treatment and in fact sequential treatment. Radiation and chemotherapy preoperatively, again, you'll find difference of opinion. Some patients, some people would go with the short course radiotherapy approach, and that is followed by chemotherapy. Others would still go for long course chemoradiotherapy. But again, I would emphasize that regardless of your personal choice, that is the key element. So in the interest of time, I'll probably need to skip the last few slides, but I think in the discussion, last point I would focus on is that it's not just about MMR deficiency, but actually we do a lot of foundation medicine testing or extended panel testing, and we pick up on other mutations such as poly mutation, which are rare, but these are the areas where patients can have complete cure with just immunotherapy approaches. What future holds is different combination immunotherapy approaches, and then looking at the resistance mechanisms in patients who fail on immunotherapy, which is a rarity, but still a reality. So thank you very much for your time and attention, and I'll be very happy to take any further questions. Thank you.
Your question and answer session will be at the end.
Our next talk is a virtual talk by Dr. Haji Chalchal, who's a medical oncologist at the University of Saskatchewan, Canada. And he is going to talk about controversies in total neoadjuvant therapy for rectal cancer. It's a virtual talk.
I would like to thank the faculty members and staff of Shaukat Khanum Memorial Cancer Hospital for providing me the opportunity to present today at this prestigious cancer symposium. I will be talking today about total neoadjuvant therapy for locally advanced rectal cancers. And we will try to address some of the important questions that we all have in our minds about delivering this modality of treatment to our patients. I report no conflict of interest in terms of the content of these slides and presentation. I hope you will enjoy it and would love some feedback after the talk. Thank you. So what is being defined as locally advanced rectal cancer? There is no universally accepted definition of locally advanced cancers. Any T3 or T4 tumors, T3 being involving the muscle layer and T4 either at the surface of the bowel and the serosa or involving adjacent organs. The other definition involved mesorectal fascia. Mesorectal fascia, as you can see on this diagram, adjacent. This is the rectal wall lumen. This is the mesorectum, and then there is a fascia that is mesorectal fascia. So anything that is less than or equal to 1 millimeter of MRF would be considered as locally advanced rectal cancer. Any node positive disease and extramural venous invasion, which I will discuss in a minute. T3 tumors have been divided clinically based on radiology into 3A and B, where they are not threatening the mesorectal fascia. T3C and D are actually threatening the mesorectal fascia, T3 with mesorectal facial involvement, and of course T4 that has been there. You will hear the term extramural venous invasion or vascular invasion in terms of locally advanced disease. This is basically the lumen of the rectum. Then there's mesorectal fascia. You can see the vessels here are not involved here. The vessels are still negative. Here there's some invasion into the venous channels, and that would be considered positive. And here it is much more conspicuous. One of the other terms that you would hear quite a bit frequently in this talk would be circumferential resection margin. So I want to clarify that circumferential resection margin is a little bit inside the mesorectal fascia, and anything that is threatening the circumferential resection margin would also be considered as locally advanced rectal cancer. Also, so the next question that we need to tackle is why total neoadjuvant therapy? We were giving neoadjuvant therapy to rectal cancer patients, but why total neoadjuvant therapy? So we know that despite concurrent chemotherapy and radiation followed by best TME, the risk of local recurrence is around 10% in T3N0 disease and higher, much higher in node positive or T4 disease. The risk of distant relapse is still at around 30% in T3N0 disease. There is a difficulty in delivering adjuvant chemotherapy after total mesorectal excision, and that has not been proven to be effective, most likely because about 30 to 40% of the patients are unable to receive this treatment or would not like to get this treatment after major surgery. We know that higher response rates have been noted in patients receiving modern chemotherapy regimens with higher complete response, and could this translate into better outcome? So objectives of total neoadjuvant therapy is to improve distant failure, local recurrence, and hence overall survival. Also, 5 large trials, and these are 3-year results. And if you can see that there is consistent improvement in pathological CR rate, and in majority of the trial it's statistically significant. However, local relapse rate remains the same. A distant metastatic disease in 2 large trials, Rapido and Protege 23, has shown improvement, which is statistically significant. Disease-free survival is also showing improvement in these 2 trials. However, there's no survival advantage so far, except in Stellar trial, which looks like a red herring because the disease-free survival in this trial was not different. So at 3-year follow-up, we know that total neoadjuvant therapy has shown high pathological complete response rate, and we all know that higher pathological complete response rate is associated with better outcome in patients with locally advanced rectal cancer. There was no difference in local control, and 2 of the 5 trials have shown improvement in distant relapse. 2 of the 5 trials have shown improved disease-free survival, and there is no improvement so far in overall survival, except in Stellar trial. I think this is because of the fact that it is a 3-year follow-up and there is a long natural history of rectal cancer recurrence even after 5 years. So I think we will have to wait to see overall survival advantage in few years' time. So I think one of the important questions that we all have in the clinics is which group of patients are suitable for total neoadjuvant therapy. So if you look at the inclusion criteria for Rapido trial, greater than or equal to MRI high-risk features of either CET4 or clinically node N2 disease, extramural venous invasion, mesorectal fascia positivity, or extra mesorectal lymph node involvement. But these patients were less than 15 centimeters from the anal verge. In the CAO trial, clinically T3, T4, node positive, less than 12 centimeter from anal verge were included. OPRA trial included all clinical stage T3, 4 or node positive. Prodigy 23, CT3 at risk of local recurrence of CT4 less than 15 centimeter from anal verge. And Stella trial included patients with T3 and T4 with clinically node positive, less than 10 centimeters from the anal verge. The next important question is, should all patients with radiologically stage T3 rectal tumor be offered total neoadjuvant therapy? So we know it from Dutch total mesorectal excision trial and several other studies that patient with high rectal cancer, that is 10 to 15 centimeter from anal margin, without involvement of mesorectal fascia, has excellent local control with surgery alone. However, about 20% of these patients can be understaged by rectal MRI or endoscopic ultrasound. So the current ESMO guidelines suggest upfront surgery if the tumor is T3A and B, but without extramural vascular invasion. However, this recommendation requires expertise in reading and conducting rectal MRIs and experience in TME surgical team. Majority of total neoadjuvant trials did not include this group of patients. It seems like there is very little benefit or no benefit for total neoadjuvant therapy in T3 tumor, clinical T3 tumor, without involvement of mesorectal fascia. And current guidelines supports the use of total neoadjuvant therapy in patients with T3 tumor with circumferential resection margin involvement, T4 or node positive disease, and all other locally advanced cancers not deemed resectable upfront. One of the important question is the high pathological complete response we are seeing is related at all to chemotherapy that we are giving, or the time that elapses during the chemotherapy after radiation treatment that could result in higher pathological complete response rate. So actually, there is only one trial that we can pinpoint on this, where it's OPRA trial. The schema was patient received 8 cycles of FOLFOX, followed by chemo-RT, and then total mesorectal excision or wait and watch approach. The second arm was chemoradiotherapy, 8 into FOLFOX, followed by total mesorectal excision or wait and watch. And we can see that organ preservation rate were higher when chemoradiation therapy were given before neoadjuvant chemotherapy compared to when it was given after neoadjuvant chemotherapy. One important question is, are patients with low-lying rectal tumor, can they have sphincter preservation? And although, we see nearly doubling of pathological complete response with the total neoadjuvant therapy, there's no convincing data that it improves the sphincter preservation rate. And I think this is basically due to difficulty in prospectively identifying patients whom conversion is possible from APR to LAR or coronal anal anastomosis. Another question that we have is, should radiation be given first or chemotherapy first? And there are 2 trials that have looked into this question, the CAO ARO trial, a German trial, enrolled 311 patients with T3 and T4 or node positive rectal cancer to 3 cycles of FOLFOX, followed by chemo-RT, followed by total mesorectal excision or chemo-RT first, followed by 3 cycles of FOLFOX-based chemotherapy, and then TME. We know that pathological complete response were higher, 25 versus 17% in patients who received chemo-RT first. However, this did not translate into improvement in ars-ora dissection, sphincter preservation, or disease-free survival. The second trial is the OPRA phase 2 trial. And here, 8 cycles of FOLFOX were followed by chemo-RT and then TME/watch and wait, or chemo-RT first, then 8 cycles of FOLFOX and then TME/wait and watch. At 3-year follow-up, compliance to chemotherapy in both arms remains the same. The organ preservation rate was better in chemotherapy, chemoradiation therapy first arm. The TME-free survival was 53 versus 14%. Longer duration of wait after radiation therapy and TME is associated with higher pathological complete response rate. Therefore, radiation first approach when using FOLFOX or CAPOX-based chemotherapy can be considered reasonable. However, this does not apply to FOLFIRINOX-based regimen, as the suggested sequence is chemo first followed by radiation therapy. This is due to the fact that we don't have data that FOLFIRINOX-based therapy could be tolerated after radiation therapy. We don't have any direct comparison to answer this question whether oxaliplatin-based chemotherapy versus oxaliplatin plus irinotecan-based chemotherapy is better as a total neoadjuvant therapy. We, however, know that in metastatic colon cancer, addition of irinotecan to oxaliplatin-based chemotherapy results in higher response rate, better disease-free survival, and some reported improvement in overall survival and conversion of unresectable metastatic disease to resectable disease, although with increase in toxicities. Prodigy 23 trial randomized patients to chemo-RT followed by total mesorectal excision, followed by 6 cycles of modified FOLFOX6 or FOLFIRINOX into 6 cycles, followed by chemo-RT, and then surgery, and then 6 more modified FOLFOX-based treatment. We know that pathological CR is in the triplet regimen was 28 versus 12%. However, local relapses remains the same. Distant metastatic disease were better. Distant metastatic disease-free survival were better in triplet arm. 3-year overall survival remains the same. So patient with good performance status able to tolerate triplet regimen can be offered this treatment based on Prodigy 23 trial. We ourselves reserve this approach in patients with very high bulk of disease or limited metastatic disease as a mean to downstage or convert them to resectable disease. This question that can rectum be preserved will be discussed further, I think, by Dr. Reyes in the talk after this one. So we look forward to that talk. But just to give the gist of it is there is a lack of randomized phase 3 clinical trial data to address this questions. There is, however, a lot of evidence coming from non-randomized data suggesting this approach may be feasible. One thing that we all had to remember that rectal cancer relapse, especially local relapse, can happen late, greater than 5 years, requiring a long-term need for follow-up in this group of patients if we choose to do so. OPRA trial randomized patients to FOLFOX upfront, followed by chemotherapy, followed by wait and watch approach versus chemoradiotherapy first, followed by FOLFOX-based chemotherapy, and then wait and watch approach. Patients who had complete response clinically after sigmoidoscopy and MRI were offered watchful waiting. A 3-year follow-up patients with consolidation chemotherapy rather than induction chemotherapy showed an organ preservation rate of 41%, suggesting that this is probably a viable approach. The largest body of evidence comes about this question is from International Watch and Wait database, patient being offered organ preservation after complete clinical response. 880 patients out of 1,009 patients submitted has complete response at a median follow-up of 3.3 years. 25% of patient had regrowth, 88% diagnosed within 2 years, 97% were located in the bowel wall, and 3% in regional lymph nodes. Distant metastatic rates were 8% and were 18% in patient with local regrowth. Disease-free survival for the whole group was quite excellent at 94% with overall survival of 85%, suggesting that this approach may be feasible. It needs to Currently, 4 randomized trials are underway to address this question. These trials have predefined criteria for complete clinical response. The consensus guidelines in 2020 of NCCN states that patients who achieved complete response clinically with negative digital rectal exam, rectal MRI, and direct endoscopic evaluation can be offered initially non-operative approach with an experienced multidisciplinary team. There is no universally agreed definition of clinical complete response, and it is defined as the absence of any tumor or irregularity at digital rectal examination, no visible lesion at rectoscopy except a flat scar, telangiectasia, or whitening of the mucosa. These minimal criteria can be complemented by absence of any residual tumor in the primary site, draining lymph node and imaging with MRI or endoscopic ultrasound, and negative biopsies from the scar. An initially raised CEA level, which returns to normal after chemo-RT, is associated with increased likelihood of complete response and pathological CR, and hence supports the opinion that clinically complete response have been achieved. It needs to be emphasized that if this approach is used, patients needs to be informed that this strategy remains at this point unproven. Meticulous selection, follow-up by dedicated multidisciplinary team is required, and aggressive follow-up with digital rectal exam, direct endoscopy, rectal MRI is required very frequently for the first 3 to 5 years. So the next question is, can less surgery or local excision instead of TME can be done in some patients treated with total neoadjuvant therapy? We know that transanal excision is considered in some patients with clinically T1 rectal tumors, and there is interest in doing response evaluation biopsies after total neoadjuvant therapy, and patients with tumor T1 or less are subject to transanal resection. However, the available data is limited, and at this stage, non-randomized, about 1/5 of patients with YPT1 or T2 tumors will have node-positive disease. At this stage, I would consider this approach as investigational. Can radiation therapy be eliminated from some patients receiving total neoadjuvant therapy? I think we all agree that the side effects of radiation therapy as GI and sexual dysfunction has made this approach as giving a significant appeal. The best data that we have is from 4ARC trial, about 495 patients randomized to chemo-RT with 5FU followed by surgery, chemo-RT with FOLFOX followed by surgery, or modified FOLFOX6 alone followed by surgery. Chemo alone group had a much lower pathological complete response, 7 versus 28%. Local recurrence though remains same, 7 to 8%. 3-year disease-free survival was also similar. Overall survival remains same. At this point, I would say that this is again investigational. We are eagerly waiting for the results of the PROSPECT trial. So in conclusion, in our clinics, we need multidisciplinary team to treat rectal cancer patients. We can use total neoadjuvant therapy in fit patients for T3 tumors threatening the mesorectal fascia and any node-positive disease. It increases pathological complete response rate, decrease the rate of distant metastatic disease, and improve disease-free survival. So far, this has not translated into overall survival improvement, but we probably need long-term follow-up. We don't offer total neoadjuvant therapy or chemo-RT for patients with high rectal tumor greater than or equal to 15 centimeters from anal margins. And we use short course radiation therapy except for low rectal cancer, where we consider long course chemo-RT. This is to facilitate possible sphincter preservation. We also give radiation first, followed by chemotherapy, unless triplet chemotherapy regimen is used. We use either modified FOLFOX or CAPOX-based regimen with FOLFIRINOX reserved for patients for T4B or where limited metastatic disease is suspected. We are not currently offering wait and watch approach unless patient declines surgery, and we are not giving chemotherapy alone unless patient has contraindication for radiation therapy. So thank you very much for your listening to this talk. I hope you have enjoyed it. Thank you.
Okay, so now we move forward to our next presentation, which is on organ preservation in rectal cancer, 9-year experience of a single center. And the speaker is Dr. Oriel Perez, consultant radiation oncologist in Champalimaud Foundation, Lisbon, Portugal. So Dr. Perez, please.
Thank you very much for the kind invitation. It's an absolute pleasure to be here. My first time in Pakistan. So thanks to the organizers, and congratulations for such an interesting topics to be tackled related to rectal cancer. So I'm just going to, I think we had a glimpse of watch and wait with the previous speaker. I'm going to just explain our experience in our institution. And we have quite a long experience compared to what's out in the literature worldwide. But this is a there was a funny comment before at the end of the session this morning regarding radiotherapy and making surgeons feel threatened by this strategy, which I think it's not. There is no reason to be worried on that. This watch and wait strategy is a strategy which is actually wanting for the benefit of the patient. It's not to be implemented widely to every single institution. So you need dedicated teams to be involved almost exclusively to a project like this. So unless you don't have the lack of having these resources in your hospital, for sure, it's something that we should not contemplate to offer to our patients. So let me share our experience. So watch and wait. Watch and wait. There is other ways of explaining what is watch and wait. Watch and wait. There are slight differences between the different definitions, but watch and wait and non-operative management or organ preservation strategy is actually a way. They all have in common one thing, and it happens sometimes to me personally by being a radiation oncologist, that it seems that these patients are actually not treated. And I'm saying that because none of the definitions is actually including the word of radiotherapy. And actually these patients are treated with radiotherapy, plus minus chemotherapy. So our patients are actually treated. But we are selecting with this strategy patients that present a biological behavior, which probably is different from most of the rectal cancer. And watch and wait and the use of definitive radiotherapy to cure cancer is not exclusive of rectum. It's been actually widely extended in other sides of the human body. And one of the biggest criticism, and we heard that, is that we don't have randomized control trials to defend this strategy. But actually, when you check of what's the evidence, and I think that anal canal is a good example to prove that also a surgeon, Dr. Negro, proved with a very small series of patients that the use of chemoradiotherapy with radical intent, nobody nowadays is questioning that we don't have evident level 1 evidence based on randomized control trials to offer that the strategy no longer. Sorry. And following to what I said, actually, we can go through all the clinical guideline recommendations, the European, the ESMO guidelines, the ASTRO guidelines also are including the possibility of offering watch and wait to our patients, and the recently new published in 2022 NCCN as well So it's everything. It's about a balance of oncological outcomes and a balance of functional outcomes that we can offer to our patients. So oncological outcomes, of course, cannot be compromised by not operating the patients. But I think we need to bring into the equation of what we are offering to our patients also the functional outcomes and quality of life. Of course, oncological outcomes and during these last decades have been highly impacted by this gentleman, Professor Bill Hill, by describing the technique that I imagine should be implemented, whatever the surgical technique nowadays to consider a rectal resection as a gold standard is the so famous TME. Then further with Professor Amjad also showing the data this morning in robotics and all the technology implemented into the surgery, moving from open surgery that Professor Bill Hill has been sharing with us these last decades and teaching it in many countries, moving to new technologies as surgery. But no less important is in the introduction of MRI, which has been bringing a lot of confidence on how to plan prospectively the treatments that we are offering to our patients. Also, metabolic imaging has been helping to stage properly our patients. Also, the evolution of radiotherapy technique, moving to 3D conformal or 2D techniques to intensity modulated techniques in order to preserve low dose to the so-called organs at risk. And with all these implementations, what we have actually gained and coming majorly from the surgical area is a very interesting improved local control with less than 5% of local recurrences, but the small benefit in terms of systemic disease. So moving to the functional outcomes, it's also well known the concept of toxic mix. Of course, toxic mix, it's clear that when we are adding radiotherapy to surgery, we are actually putting into controversy the function in terms of sphincter function. And it's clear that regardless the type of radiotherapy, the results of fecal incontinence are worsening if we are adding radiotherapy to surgery. But what we also know is that besides of impacting negatively to the fecal incontinence when we are adding radiotherapy to surgery, there is also a negative impact in terms of sexuality, both in male and female. And that is also related to the position of the tumor. So lower tumors are going to be more affected, and also depending on the type of surgery. There is a concept here that it also needs to be tackled, and it's that rectal cancer is as most of the tumors are dose depending. So that means that the higher the dose that we are able to deliver, the higher the probability this tumor respond. But also time is an important factor. So if we irradiate, as we have classically been doing with short course, and we immediately surgery, we cannot expect, because there was not time enough, that we will get any downstaging or downsizing of that tumor, compared to if we wait longer. And actually, where we gain time for the cells to be driven to a dead path, in order to be able to get better responses. So these watch and wait programs normally tend to recommend to wait a little bit longer. So if we wait a little bit longer, theoretically, based on this course of response after radiotherapy, we will achieve higher rates of downstaging and higher rates of pathological complete responses. So what is a complete clinical response? What is a near complete clinical response? Or what is an incomplete clinical response? I think that both sides, complete and incomplete, are easy to define, whereas near complete is something much more complicated, because when you meet the criteria of getting a flat white scar in the endoscopy, which is surrounded of telangiectasia, or our specialist radiologist dedicated into rectal cancer is telling us that we get a tumor regression grade 1 or even 2, if you want, without diffusion or restriction in the diffusion signal, then it's easy, because you say, well, we achieved a complete clinical response. There is a debate on the MDTs. Can we offer the possibility of watch and wait to this patient? well, it's something that it needs to be discussed openly with our patients. And also the other way around, when we don't get this criteria and actually the tumor is not downsized, is not downstaged, and there is visible tumor in the endoscopy, then there is a no-brainer. This patient needs to be operated for sure. This is the difficult side. So we achieve a good volumetric downstaging. We achieve very nice scar on our endoscopy assessment, but they are still not meeting a complete clinical response. So for this, there is a recently published paper at the end of last year where actually the so-called experts tried to find consensus on how we would define a near complete response and what to do in front of these patients. Well, the consensus was not met, so we remain on the same uncertain situation. But well, when we consider watch and wait strategy that we can offer to our patients, of course, reasonable doubts arise, and that would be, I would suggest, I think that would be tackled in these 4 questions. So, do clinical complete response patients have a favorable prognosis? Are we putting patients with a complete clinical response at risk by deferring surgery? Do they have comparable survival to the patients that have been operated? And do clinical complete response have any functional or quality of life advantage compared if they are not operated? So some evidence reporting this. Well, I think that it's almost 25 years that Professor Angelita Bragama published this data, and what we could see is that actually complete clinical response present with a better prognosis factors in terms of local and distant recurrences and overall survival compared to those patients that do not achieve a complete clinical response. Then this is data coming from our institution. Actually, Dr. Irfan is the one who reported this data very nicely when he stayed in our institution for a long period of time. And actually, what Irfan published was also very interesting. And when we want to see what happened to the patients that go straight to surgery after neoadjuvant radiotherapy, and I'm talking about not deferring the surgery, compared to those patients that are deferred into the program and then they regrew and then they are salvaged operate. What he could prove is that there are no significant differences in terms of local recurrence in distant recurrence or in overall survival. Then when we talk about survival, we also have data coming from different surgical series, and these surgical series are comparing patients that have been managed in watch and wait due to their complete clinical response achievement compared to those patients that are actually followed in surgical series, and this is a propensity score match. And actually what we see is that 2 and 3 year overall survival are totally comparable. And then also in terms of non-regrowth disease-free survival. When we put our focus into function and quality of life, what we see here is actually patients that have been assessed in terms of bowel function in the VASI score, and this is a trick. This is not comparing watch and wait compared to TME, but compared to local excision stem. There is a clear advantage to not touch the bowel, let's say, even endoluminally or not in a complete resection. So there is clear advantages in not touching, but also a quality of life measure that could be colostomy-free survival. In terms of function and quality of life, there is a clear benefit when we compare in the Larsa score in the different domains of Larsa score, remaining clustering and urgency for those patients that are not operated. So we will move now into our experience. So we started this watch and wait program in 2013. So next year is going to be 10 years. And actually, these are some specifications of the radiotherapy that we deliver to these patients. So classically, we use MRI and PET-CT for planning. So that means that actually we are tackling the real disease, either morphologic or metabolic. So we are not using the standard CT scan that is actually overexpressing the fields that we need to treat. We also implemented since the very beginning in 2011 techniques that are using intensity modulation irradiated. We defined something different from the real recommendations of what to irradiate. It's pretty well defined. There are international consensus on irradiating the whole of the pelvis, but together with Professor Bill Hill, we discussed that deeply years ago, and we came up with a definition of total mesorectal irradiation in case the disease is confined within the embryological compartment of the mesorectum. And we would define it as extended total mesorectal irradiation when there was proof based by imaging, especially MRI, of existing disease outside of the mesorectum. We also implemented dose intensification, both with long course and short course radiotherapy, and we implemented a strict protocol of anal canal sparing when the disease was not involving the anal canal. With that, we were actually expecting better results in terms of tumor response, but also in terms of toxicity and anorectal function. So this is a resume of the last moment that we made an interim analysis of the patients that have been irradiated in our institution. That was done in April this year. We will do a reassessment of all the patients in April next year. I'm sorry, it's not freshly reviewed, but it's got my a review that it's more or less 6 months old. We have been irradiating at the Champalimaud Foundation at that moment 186 patients. Most of the patients were T3 patients, but if you see T3 and T4, we have more than 80% of the patients. So we are not irradiating early stage unless the patients are very low sitting and are actually not willing to move to directly for an APR. So that is intentional organ preservation strategy, which is defined on the MDT basis based on the discussion initially of that patient. Most of the patients are stage 3, but also look at that we have more than 20% of the patients metastatic offering a local regional strategy. Then if we again, the big majority of them are low-sitting tumors, and the big majority of them, unless we have 22% of patients that were not reported in initial MRI, EMBI positivity. So our patients that are presenting local regional high risk features of recurrence locally and at distance. So if we see how we are treating the patients, more or less 50% of the patients have been treated with long course chemoradiotherapy. The rest of the patients have been treated with short course. We have 2 modalities of short course, incrementing the dose with an integrated boost in order to seek for better clinical responses. But again, in this case, for example, SIB short course, 44% of the patients were presenting with metastatic disease at the moment of our diagnosis. And the classical 5x5, we also have a percentage of 40%. Is it 40%? 1% of T1s, and that is a trick. So it's not T1s like a patient is going to be managed with radiotherapy, but it's T1s that have been, let's say, suboptimally resected elsewhere, and they come from a proposition of an APR for a patient which received a polyp, which was a T1, and actually it needs to be tackled now with an APR. And we offer also inside of a protocol, a research protocol, short course radiotherapy in order to also, again, to do organ preservation. Well, if we assess these numbers, and I'm going to run in for the sake of time here, what we see is these are the results of the patients managed, and removing stage 4 and T1 polyps from the whole cohort. What we see is that we get a non-operative management rate of these patients that again are very, very selected and are very, very advanced in terms of local disease. As you saw, we get a 44% of non-operative management with a clinical complete response rate of 42 and an organ preservation rate of 45. and also take into account that even being very, let's say, tricky at the moment of assessing clinical response, we get a 15% of pathological complete responses. And if you add, for example, these 15% of pathological complete responses to this 42% of clinical complete responses, actually the numbers are pretty nice on how we are performing in terms of tumor response. If we assess the patients that have been operated, 20% of these 20% of the total patients experience a regrowth, which goes in line of what literature is saying, and 36% of these patients were operated due to persistent disease, so that disease that did not respond. Out of this regrowth, what we can see is that 100% of the patients have been salvaged with surgery, and the median time to regrowth was 15.2 months. And so this is pretty much in line with what other series are publishing. If we put into context these two subgroups, so the most favorable and the most unfavorable ones, we see that we still get pretty nice and interesting data to assess. So these are stage 4 at diagnosis patients, and what we can achieve is a complete clinical response in 38% of these patients and resection rate of 26%. So more than 50% of these stage 4 patients are actually tackled in a curative intent. And this, of course, these very early polyps, the non-operative management and the organ preservation rate are very high, except from a patient that did a regrowth, and the regrowth was not in the scar or in the bowel loop, but it was a single lymph node that it was growing. And of course, in that moment, we decided to operate. So what we get in the foundation nowadays, and that is it's been counted last week, more than 200 patients have been treated with long course and short course. So 76% of these patients were low-lying tumors, 66% were T3s and 20% T4s. 21% of these patients were stage 4, and 58% of them were presenting with EMVI positive. And overall, the complete clinical response rate of our institution is 45.3%, which is very nice. So I'm not sure what is my time, but I'm 21 minutes, so I will escape this international watch and wait database that we are actually actively involved as members of the founding. Just to show you that more than 2,000 patients have been already registered. We are the fifth institution now that have introduced more patients into that. A lot of publications coming up retrospectively from assessment of this international watch and wait database, most of them coming out from our institution. So as a summary, I would like to say that organ preservation constitutes a paradigm shift in the management of patients with rectal cancer, which achieve a complete clinical response, enabling patients with a complete response or a near complete response after radiotherapy to safely avoid the morbidities associated with radical surgery. The main reason for exploring organ preservation is the potential to preserve anorectal function, thus avoiding the need of permanent colostomy and maintaining quality of life. And data from several studies, including International Watch and Wait database, indicate that deferral of surgery seems oncologically safe. Let me show you our group of dedicated to rectal cancer, which is led by two very important actors here, Professor Bill Hill and Professor Judd, which I think they are doing an excellent and brilliant job of driving this bus of all these young people. And thank you very much for your attention.
Thank you very much, Dr. Perez. Thank you. We'll take the questions at the end of the sessions, and I'll request the participants if they have any questions. So you prepare them right now, because the next talk is a virtual talk. It is by Dr. Nick Powell, who's a consultant gastroenterologist at Imperial College London. And he's going to talk about gastrointestinal side effects of immune checkpoint inhibitors. It's a virtual talk.
Well, firstly, thank you very much for the invitation to speak at this exciting meeting. Regretful that I can't join you in Pakistan. I would absolutely love to have done that, but I am speaking to you from London. My name's Nick Powell. I'm from Imperial College, and I'm going to be talking to you about the gastrointestinal side effects of immune checkpoint inhibitors. So these are my disclosures. So I'm based at the Hammersmith Hospital site in West London, and my lab actually is based on the 10th floor of the Commonwealth building. You can just see it in the background there. But I also spend now a day a week at the Royal Marsden Hospital, which is also in West London, which is one of our big cancer hospitals. And that's really testament to the fact that immune checkpoint inhibitors are becoming so commonly used. And my clinical week that I do there at the Royal Marsden is purely dedicated to seeing patients with immunotherapy-induced colitis. This slide will be familiar to you. Patients exposed to immune checkpoint inhibitors develop a whole raft of different immune-mediated diseases across different organ systems, and almost any organ system can be affected. I've highlighted in red some of the most common ones. And again, the one that I want to talk to you about today is really colitis. You can see in the graph on the right-hand side how commonly this occurs in patients to which immune checkpoint regimen that they are exposed to. So anti-PD-1 therapy, you'll see about 1 in 5 patients will develop immune-related diarrhea. With anti-CTLA-4, that goes up to about 1/3 of patients. You can see in combination therapy, almost half of patients exposed to combination therapy will develop immune-related diarrhea. When do we expect to see immunotherapy-induced diarrhea? And these are data from melanoma patients treated with either anti-PD-1 or combination anti-PD-1, anti-CTLA-4 therapy. And in anti-PD-1 monotherapy, you can see patients tend to present 1.8 months after exposure, but really you can see very wide incidence bars where that can be very early after exposure or very late after exposure, even 2 years following exposure to anti-PD-1 therapy. Similar situation with combo therapy. I mean, the kinetics of presentation are accelerated with patients developing disease as early as on average, about 5 to 6 weeks after exposure, with again quite wide differences in when that can present early to late. So what are the implications of developing immunotherapy-induced colitis? Well, I think it has a real major impact on that patient journey. So development of colitis is the most common reason for immunotherapy-treated patients to land themselves in hospital. It's the most common reason for either permanent or temporary interruption of immunotherapy treatment, which is often very frustrating and scary for patients to suspend this potentially life-saving therapy. It's also the most common cause of treatment-related death, and that's usually from a consequence of colonic perforation, which occurs in up to 5% of patients and is especially common in patients treated with anti-CTLA-4 containing regimens. So this will be very familiar to you guys on how you grade the severity of immunotherapy-induced diarrhea using this CT-CAE grading system. I show this slide for a number of reasons. The first is that I think on average, it sort of underestimates the severity of disease. By way of comparison, I show you the grading system that we use in ulcerative colitis. And you can see that a patient with grade 3, which is the worst stool frequency score, subscore in the Mayo score, is a patient with over 5 stools or equal to 5 stools a day. You would only score grade 2 on the CT-CAE grading system. So it's clearly, at least if you compare it to ulcerative colitis, the very worst severity for the Mayo score would only be grade 2 in the CT-CAE grading system. I also mention it because as a gastroenterologist, the CT-CAE grading system was completely new to me until I started seeing patients in my dedicated clinic. So when you're engaging with your gastroenterology colleagues, this won't be a familiar system to you. So just to converse in the language that the common gastroenterologists will understand. So stool frequency is certainly important to us. Nocturnal symptoms, rectal bleeding and abdominal pain are some of the important symptoms that we would look out for. I also think this is an important slide in that the grading of from the CTCAE grading system does not at all correlate with the severity of mucosal injury. And you can see on the right-hand slide here, I'm showing you two patients with grade 2 diarrhea, the one on the left having an essentially normal colon, and the one on the right having ulcers and contact bleeding. Similarly, with grade 3 diarrhea, you can see patients with essentially normal colonoscopies, whereas this patient's got deep ulcers, and this is the kind of patient I would worry about in terms of perforation. The one symptom that does correlate quite well with the severity of mucosal injury is rectal bleeding, and that's certainly a red flag symptom and one that I pay special attention to when I see that in my patients. I'll talk a little bit about the management of immunotherapy-induced colitis now. But in the UK, the British Society of Gastroenterology, we generated some guidance on this a couple of years back now, and the Americans have also generated gastroenterology-specific guidance on the management of immunotherapy-induced colitis, which is very sympathetic and similar to much of the oncology community guidelines. Investigations, I think, are mostly straightforward and are directed at, one, confirming that there's definitely inflammation there, because that's the basis of treatment, but also in terms of stratifying the severity of disease. So full blood count and CRP and albumin are quite useful. I'm a very big fan of fecal calprotectin. That really tells me whether a patient genuinely has inflammation, but of course it's no substitute for endoscopic evaluation and directly visualizing that mucosa. And I'll talk about that in a bit more detail in a moment. And of course, we want to make sure we've got the right diagnosis. So some of these other tests are based on excluding competing diagnoses such as infection. CMV, I think, is more of an issue in patients who've been exposed to lots of steroids, which is not unusual in this setting. Thyroid function tests, I think, do hold a place, although most patients, as you will know, who do present with thyroid dysfunction as a consequence of immunotherapy tend to be destined for hypothyroidism, but certainly in that initial phase, you can see hyperthyroidism. I've certainly seen plenty of patients with pancreatic insufficiency, so fecal elastase is a useful test here. And upper GI inflammation is also commonly found in patients exposed to immune checkpoint inhibitors. So checking for celiac serology, and also in patients that certainly have upper GI symptoms or have symptoms that are resistant to our treatments, I think looking in the upper GI tract for evidence of small bowel disease is often useful. So these are the key tenets or cornerstones of treatment really in immunotherapy-induced colitis. So in general, I think it's useful, particularly in patients with more severe disease, to withhold immunotherapy. Patients can also present with pretty torrential diarrhea, so paying attention to rehydration can be useful here. But really, corticosteroids are the mainstay of therapy for patients with immunotherapy-induced colitis. Oral prednisolone for those with milder disease, and those with more severe disease needing intravenous methylprednisolone. Again, those with only microscopic disease or very minor symptoms, I'm a big fan of these second-generation steroids, which can be administered orally but have minimal systemic side effects. And I will dig into this in a bit more detail in a moment, but we certainly have second-line agents for patients who are steroid resistant, including some of the biologics that we commonly use in patients with conventional inflammatory bowel disease. I don't want to concentrate too much on this rather complicated slide, but there are a couple of points that I did want to make about it in terms of a treatment algorithm. And that's, I think, patients benefit from very early administration of steroids if they've got good going diarrhea. And I tend to use 40 milligrams in my practice of prednisolone. But the really key point that I wanted to make here is that patients not responding within a relatively short time frame, so let's say up to 5 days, if you don't respond to oral prednisolone in that time, I would escalate to intravenous corticosteroids. And I do use methylprednisolone in my practice, which has very much been driven from my oncology practice. actually, and 1 milligram per kilogram is certainly a decent dose to be going with in that setting. That's very much borrowed from the acute severe colitis, ulcerative colitis treatment algorithm, where we use 100 milligrams of hydrocortisone 4 times a day. That's a very similar dose in an average weighted patient. And again, I think this is a really important principle here. Patients not responding to intravenous steroids within a relatively short time frame, it's time to switch strategy and think of your rescue therapy. And again, these are data, or this strategy, I guess, is very much borrowed from the acute severe colitis treatment pattern. And again, in patients with acute severe ulcerative colitis not responding to IV steroids within 3 days, we very much opt for rescue therapy with infliximab. And of course, I've mentioned some other rescue treatments here, and we'll talk about those in a bit more detail in a moment. These are data from one of my research fellows who's done a sort of meta-analysis looking at how effective anti-inflammatory therapies are in patients with immunotherapy-induced colitis. And one of the things that Harjir found is that by assimilating the 33 studies that have been published with over 1,000 patients so far, developing immunotherapy-induced colitis response to steroids is round about 60%. And interestingly enough, that's pretty much the same response we see in patients with acute severe colitis. There's slightly less data available on infliximab. So again, Harjir found 17 studies over 300 patients showing that the response to infliximab in steroid-resistant patients is round about 81%. This is, I think, going to be an important emerging story about how patients, the complications that we may expose our patients to by treating them with immunosuppressive treatments. So on the left here, I'm showing you a graph from the Sloan Memorial, the Memorial Sloan Kettering rather, in terms of melanoma patients who've been exposed to immune checkpoint inhibitors, and those that have been additionally exposed to steroids or infliximab to immunosuppression. So those not exposed to immunosuppression, the number of those patients developing serious infections, and that's defined by requiring hospitalization and or intravenous antibiotics, is usually pretty low. However, if you look at the patients who are exposed to immunosuppressive regimens, that jumps to over 13%. So infection is a concern when we expose patients to these immunosuppressive regimens. We saw a very similar situation in over 100 patients with immunotherapy-induced colitis at the Royal Marsden. Again, infection being there in about 15% of patients, including some severe infections like pneumocystis. We also saw psychiatric and metabolic disturbance in those related to steroid treatment. This is an interesting study as well, suggesting that this is in patients developing immunotherapy-induced hypophysitis now, stratified according to whether they were treated with low or high dose steroids. And this is perhaps slightly more concerning. These are all patients with melanoma treated with ipilimumab, and you can see that survival was impeded in those treated with high dose steroids, suggesting that steroids may even impact on the efficacy of immunotherapy. So this is something we're certainly going to have to think about more in the coming years, about how we treat our patients developing immunotherapy-induced colitis. And I want to say something about vedolizumab as well, which is another monoclonal antibody that we use to treat patients with immunotherapy-induced colitis, again borrowed from conventional inflammatory bowel disease. Vedolizumab is an interesting drug because it's a gut-specific monoclonal antibody that stops the trafficking of lymphocytes to the colon. And these are data from 2 centres in the UK from Mimi Wang's group. Again, if I just focus on the right-hand side of this graph, initially, you can see that vedolizumab and infliximab treated patients, good rates of clinical remission in patients with steroid-resistant immunotherapy-induced colitis, showing good levels of clinical remission. In patients with vedolizumab, they also had less exposure to steroids. They were less frequently required to be admitted to hospital, although the time to response tended to be slightly delayed compared to infliximab. So again, good promise from this drug as well, which is also available as a subcutaneous formulation as well, which may be useful for ambulatory patients and keeping people out of hospital. I wanted to touch on endoscopy, which I think is also a particularly valuable test in patients with immunotherapy-induced colitis. You can see these are all patients I've scoped with significant inflammatory disease. Clearly, this helps confirm the diagnosis. It does allow us to exclude other causes and get biopsies to look for CMV, for instance. But where I think it really does hold its own is assessing the severity of disease and stratifying treatments. And I'm going to just talk about that in a bit more detail now. So I think these are interesting data from Amsterdam, and they've been corroborated since by Mimi Wang's group from the MD Anderson, but essentially showing you that people with ulcers, those who have severe inflammation and those who've got inflammation across the whole colon, these patients are likely to fail steroids. So over 70% of those patients with any of these features will fail steroids and require rescue therapy. So in my practice, if I see patients with ulcers like this, I will fast track those patients to a rescue therapy, so either infliximab or vedolizumab. And then this is just a word of warning, but this will be very familiar to this audience, that certainly in our practice at the Marsden, the use of immunotherapy is exponentially increased. This graph's a little bit out of date now, but you can certainly see in both the clinical trial and routine clinical practice settings that our use of immunotherapies has rapidly increased. And if you just compare that to conventional inflammatory bowel disease, number of actively recruiting clinical trials as of November 2020, this was dwarfed by the number of clinical trials going on with immunotherapies. So immunotherapy colitis is a problem that's coming for gastroenterology. This is an oncology dominant audience today, but certainly this is a slide I like to show my gastroenterology colleagues to say to them, if you're not getting engagement with if you're not engaging with your oncology colleagues as a consequence of this problem, you certainly should be, because this is a problem that's coming to gastroenterology clinics now. So just in conclusion, I hope I've convinced you that colitis is a common and important and severe complication of immunotherapy. In most patients, rapid institution of corticosteroids is effective, but we do have rescue therapies available, including anti-TNF and vedolizumab. I've shown you that endoscopy, I think in particular, is a valuable test, not just to confirm diagnosis and exclude infectious causes, but really it holds its own in stratifying treatments. In those with ulcers or pancolonic disease, we want to be thinking of fast tracking those patients to our second line agents, in particular to infliximab. And of course, as I've mentioned, this audience needs no convincing that immunotherapy use is anticipated to really grow in the coming years. And as gastroenterologists, we're going to be seeing a lot more of this problem, and working together with our oncology colleagues and this community, we hope to make better treatment options available in the near future. Thank you very much.
Okay, now we move on to our next, our last section, which is question and answers. I would first of all would like to invite Dr. Khurram Khan and Dr. Oriel Perez to join us on stage. So we have 15 minutes for question and answer section.
Yeah, hi. My name is Fahad. I have a question for Mr. Perez. So what is your criteria for short course radiotherapy? And what is the dose? How much dose do you give? And secondly, what is the time frame in which you operate upon, you would like your surgeon to operate upon these patients?
Thank you for your question. Well, it's a difficult question because I am biased for short course. So, but anyway, it's not upon me decide to treat a patient with short course or long course. As I mentioned, I think we decide this type of managements on an MDT basis. So I can explain that, and it was also mentioned here that this, I think it was my colleague who said that using short course or long course, it's still, we don't have enough data to defend one position to the other. If we want to somehow observe the small randomized, the few randomized trials that compared short to long course, we actually cannot find differences, oncological differences. And we also need to take into account that the short course has traditionally been followed by immediate surgery. So having said that, the way we use short course in our institution. So the easy way to explain that would be when a patient is at high risk of systemic disease. When a patient is already stage 4 and you don't want to invest long time in tackling the primary tumor, and you are somehow in a hurry to, for example, start chemotherapy or a TNT strategy, short course is preferable because, of course, it is less time required to invest to irradiate the tumor. When a patient, for example, is frail for chemotherapy, it's a no-brainer, I think, on those cases. And it's basically that. Then there is another, a second question is when the patient is better to be proposed for surgery. Well, traditionally, as I said, patients were immediately operated, eventually 3 days after the end of radiotherapy, and that was due to the inflammation component that was actually making life a little bit more difficult for surgeons to lead with that. But if we go to analyze, for example, this Stockholm 3 trial that allowed short course to be immediately operated or to defer surgery, actually, if I recall well, unless, of course, a significant, more acute GI toxicity in terms of diarrhea, there were no comparisons there were no differences in terms of surgical complications. So knowing this and then having the philosophy of giving the chance to all our patients that have been irradiated to be assessed clinically after the end of neoadjuvant treatment. We don't operate patients before 10 weeks after the end of radiotherapy. So that means that our patients will finish either long or short course. We will give 10 to 12 weeks to assess clinical response. And then if complete clinical response criteria are not met is when we operate patients. I'm not sure if Professor Amjad wants to add something related to that, but I always ask him, or at least I used to, if he was, in his impression, if he was getting into more trouble by waiting. And he's here to respond, but at the moment that when I asked, he never pointed on that. But
I think this is a good myth for the surgeons to break. So I make it easier for surgical mindset because there was 6 weeks versus 12 weeks. You know, we ran this in England, for example. You know, by post-chemotherapy therapy, when would you operate? What is the best optimal time to operate? So I think if we operate within 6 weeks, so at 6 or 7 weeks, you get more water while you're operating. You get a lot of edema, which is a technical challenge in an obese person, for example, particularly when the margins are threatened and you're not too sure. If you wait longer than 16 weeks, which often happen in our watch and wait program, as you know, you get a lot of fibrosis to deal with. So that's the trade-off between the two. We have had now considerable experience in operating on regrowths. These are patients who had the treatment a year, 18 months, nearly 2 years sometime, and we are operating on them at that stage. At that stage, it almost looks like no chemoradiation effect by the time you get around to operate on these patients. So it's a way of how bodies sort of manage this edema. We have looked into it. I think it was Irfan who wrote that the delayed operation following 14 weeks have no bearing in terms of short-term outcome as well as the margin positivity. So if at 6 weeks treatment, as you know, it shows that there is a response in tumor, we continue to wait. And we continue to wait unless there has become very obvious that this is never going to be a complete clinical response, and then we operate. While I've got this opportunity, this is something very striking. When I probably looked at this data, we presented at Shaukat in our meeting when you were there presenting. You probably have the highest complete clinical response rate that I have seen, 42%. If you take those 15% out who were YPT 0, which we got it wrong and operated on. Any particular reason why you have higher than normal reported CCRs? Are you using different technique? Have you got better machines? Are you selecting well? So what is contributing to this?
Well, the only difference, or at least evident difference that I could point in these terms is our particular dose escalated protocols. So it is widely accepted that long course should be delivered no less than 50 gray in at least five weeks. We have those escalated until 60. So that is approximately, if I'm not wrong, 20% more of the dose. So, and there is on the dose response curve, or the patterns of those response curves, that is substantially on the steep part of the curve. So we are theoretically increasing cell death in that frame of the curve. For the short course, and especially short course when we have macroscopic disease visible, that would not be applied for those polyps that I was showing. But when we have macroscopic disease, we have those escalated to the tumor between 30 to 35 gray. So that is 1 to 2 gray more per session during those days. That is almost 40, 50% more biological effective dose. That could be an easy way to explain why we get these these response rates. But again, clinical response rate to rectal cancer, it is a tricky field to explain, because why do we? So the answer could be back to you is like, why do we use standard doses and still like these? When we use a standard doses still like that, we have 15-20% of complete responses, and why, if we dose escalate, we still have like 45% of patients that do not respond. So that is getting into radiobiology. That is very difficult, and of course, that is also the genetical and molecular profile differences between tumors. But yeah.
Okay, any other question?
Yeah, can I ask a question to Oriel, you, please? We in this part of the world, in the West, you get a signet cell mostly in the upper GI, while here we get a signet cell in the lower GI, especially in the younger population. Have you noticed any difference in your practice that the patient who have got these type of tumors, what is their CR rate, response rate in your practice?
You mean esophageal?
No, I'm talking about the rectal signet cell.
Oh, signet cell in rectal cancer?
Yeah.
Well, that is very rare for us, or at least we don't search for that. And I actually cannot contribute into a reasonable answer for this, because I think that in my practice I have maximum seen 2 patients, and based on that I could not associate this specific type of patients with in related to clinical response to radiotherapy. I don't know.
Because that's something which, Asghar is here, and I think Imran is here, that in this part of the world, we get in our younger population, we get quite a number of that morphology in our practice. Okay, that's fine.
Sorry.
The radiation response is, I think, better. Because, radiation, as long as I know, you are the expert, you can tell me, if the tumor, even any chemo radiation, if the tumor cells are dividing quickly, they will respond more. So obviously but most of these tumors, unfortunately, the recurrence rate is pretty high. It is difficult to cure them. So that's what I was asking, that in your practice, do you have, that how many you have treated, which have gone to, which are lucky enough to go to wait and watch?
No, and
But obviously, if you don't have
Yeah, we
seen them
don't-
that
it
many,
is-
so it will be difficult to.
it is extremely rare. And then the few cases that I have seen, they are not even stratified in terms of if they respond better or worse.
We have a small number of signet cell tumors as well, which we've treated. I think, as you mentioned, the biology is quite aggressive, both in terms of chemoresistance and risk of relapse. But because of the small numbers, there are no randomized data to show one way or the other. So we treat them in a similar fashion as we would treat other poorly differentiated rectal adenocarcinomas. One thing I would say is that we have a slightly different strategy. Actually, we go with less rapido approach, but more with the prospect approach. So we tend to offer 3 months of FOLFOX chemotherapy. And in our practice, although we haven't published the data, it's small numbers. Actually, we've seen that the response rate is quite good. And I would say probably about 10 to 15% of the patients then subsequently at restaging do not require radiotherapy at all, which is debatable whether you take that approach or not, because again, no randomized data to show that. But it's great if you can escape radiotherapy altogether, as you showed. The toxicities with both surgery and radiotherapy are more complex.
Okay, can I ask you a question? Have you started using immune checkpoint inhibitors in MSI high rectal cancers as new adjuvant treatment?
Yes, absolutely. So we, in fact, the 2 patients that I showed actually in my talk, even before the time the data came out, that was note 177 study data. So the response rate is so exceptionally high that you're almost guaranteed to have a response. The other thing that we do quite commonly is that we do the foundation medicine panel on locally advanced or metastatic disease patients. And I've personally picked up 2 patients with poly mutation as well, who had complete response and really
I mean to say that is this a nice approved immunotherapy?
No,
as a
it's
new-
not nice approved. So you have to apply it through a special funding program. So you can get it, but it's not nice approved at the moment.
So any other question?
So if there are no other questions, I would like to thank all the participants for a very patient hearing and for the presenters for excellent thought-provoking presentations, and to our virtual presenters as well, who also presented very important papers. So thank you very much, and this concludes this session.